All right, good morning, everybody. I am Dr. Joshua Hardman. And I gave a lecture here about a year ago. Some of you guys might remember who are here. I refer to myself as BMD. This is a reference to when I was stalked by a creepy person at the gym and they sent out pictures of me. That was the greatest day of my life when I found out about this, and I am still living off the glory. I'm like one of those guys who peaked in high school and still always refers to as a winning touchdown in high school, and that's the best thing that ever happened to me. Anyway, so today I want to talk about this phrase or this concept or this idea that we use a lot in medicine. Trust me, I'm a doctor. About a year and a half ago, I was talking with my teenage son, who is 15. He was 14 at the time, and he's going through a phase in his life where he is absolutely obsessed with being masculine. He wants to be the most manly, masculine person on the planet. He listens to people like David Goggins and Jocko Willink, and I guess it could be worse, but he was arguing with me one night about which one of us was more masculine. And yes, as a 49-year-old man, I actually argued with my 14-year-old son about who was more masculine. That's how mature I've become in my 49 years on this earth. And he started asking me all these questions. He's like, yeah, well, look how many push-ups I can do. And I was like, I'm in the Army, I can do push-ups all day long. He's like, yeah, but, and he starts listing off all these things, and I was winning hands down every time, and I was feeling pretty good about myself, and he gets really desperate, and he's like, yeah, but how many people have you killed? And I was like, whoa, wait a second. This conversation has just taken a really dark turn. For one thing, you're 14, and I'm pretty sure you've never killed anyone. Second of all, we aren't Mongolian steppe nomads here, okay? We aren't Comanches. We don't rate masculinity by how many people we've killed. But I said, you realize I've been in the Army now for 30 years. And he's like, have you ever actually killed anybody in the Army? And I thought about it for a second. I was like, actually, no, I haven't. But it doesn't matter. I still win this part of the argument because I am a doctor. And doctors, as we all know, have killed lots of people. And ironically, I have killed more people as a doctor probably than I have as a soldier, which is amusingly ironic, I think. Anyway, so I won the argument, no, never fear, but I brought this up. Now, this is actually from a 2006 study. The number of premature deaths associated with preventable harm to patients was estimated at more than 400,000 per year. The numbers, if you actually look at these studies, they're all over the place, somewhere between 90,000, 500,000, depending on which study you want to look at. This one is specifically about inpatient medicine, about 400,000 people. This was from 2006. I don't know whether it's changed since then. I could not find a more updated number since then. I would like to believe that since this study originally came out, hospitals take all sorts of precautions to prevent mistake-related deaths, and I think we probably have made some progress. I would like to believe anyway. I could not find any studies at all about how many outpatient deaths there are associated with medical care. This was, according to this one is just about doctors' handwriting, claiming that about 7,000 people a year die in the U.S. just due to doctors' illegible handwriting. I have to tell you though, this number, I could not find this study. This was quoted about a dozen places. I could not actually find the original study anywhere. And I don't know if, so I don't actually know if this is true. And this was also from 2006, and obviously we don't write as much as we used to, so I'm sure that number is different now. And then this was a news article, and it was quoted about a dozen different places. The medical errors are the third leading cause of death after heart disease and cancer. Once again, I could not actually find the original study that these news articles was quoting. This one right here is from MSNBC, and they didn't actually link the article. They just said from a recent study from Johns Hopkins University, and they didn't actually have a link. I have to tell you, so I spoke with Dr. Bowden last week and said I was going to send her this, my slides last Thursday, and all I needed to do was track down some of these references, and I was up until 11:30 last night trying to find these references, and I still cannot find the original studies that these are quoting. So take that for what it's worth. But this is I think it's not unreasonable to say that hundreds of thousands of people die nationwide, or their deaths could have been prevented by better medical care. So I want to talk a little bit about this, about the mistakes that medical providers make. Not just doctors. I'm not picking on myself necessarily, but the medical community as a whole. I want to go through a handful of mistakes, some famous medical mistakes, okay? Some of you are going to be familiar with these, but I think they're worth discussing. How many of you guys know the story of James Garfield? Does anybody know that story, the president of the U.S.? You nodded your head.
The other day in my
Were you?
Yeah.
Yeah, what do you know about the story?
Was he shot? I can't remember if he was shot.
Mm-hmm.
Anyway, so his doctor, the army doctor was coming in to save him, but his doctor pushed him out of the way, didn't believe in hand hygiene, and died of an infection.
That's exactly right. Yeah, President James Garfield was shot in the back. And just kind of as an aside, President Garfield is a fascinating person. He is the only person who became president against his wishes. He was actually nominated by the Republican Party against his wishes, and he said he didn't want to have anything to do with being president, but they voted for him anyway. Anyway, so he was shot in the back. His army doctor, like you were saying, had seen these injuries before in the Civil War and said he is going to be fine. This is not a fatal injury. Just leave it alone. He will heal up just fine. His doctor, who I don't remember where he'd been trained as a doctor, but he was pretty convinced that he needed to save President Garfield. So he just kept, every single day he was probing around in there. He had these big long metal probes. He'd probe into the gunshot wound and tried to find that bullet, and he did it for months. He didn't die immediately. He took weeks and weeks to die, and he died of infections because his doctor refused to leave him alone. He would probe it with his fingers. He had these big metal probes he was probing in, and it eventually killed him. Okay, James Garfield was an extremely intelligent person, and he was also very, very healthy. And if you read the accounts of his after of this death, he was actually recovering a couple of times, and his doctor refused to leave it alone. He kept making this worse and eventually killed him. Okay, so how about Dr. Semmelweis's hand washing recommendations? Most of you guys have heard this story. I'm not going to rehash the whole thing, but for those of you who might not be familiar with it, Dr. Semmelweis was a gynecologist in a hospital in Vienna, and he figured out that pregnant women who were delivering, they kept dying of infections, and they were dying at higher rates where the doctors were treating them than in the wings where the midwives were treating the women. Okay, and he figured out that if you would just wash your hands, it would dramatically decrease rates of infection, and a lot more women would live through delivery. And he was absolutely excoriated. He was dragged through the mud by the medical community, and took, I don't know how long, took decades before his hand washing routine was adopted by doctors, and he was vindicated. But it destroyed his life, destroyed his career, that nobody would believe him. Okay. How about this one? How many of you guys remember this? Back in the 1950s and 60s, my grandmother, she was actually a nurse in World War II, and when she came back from the war, she started having kids, and she was told in no uncertain terms that formula was far superior to breast milk, and she needed to be feeding all of her kids formula. She needed to not be breastfeeding. Luckily for my mom and my aunts and uncles, she, for whatever reason, didn't believe it, even though she was a nurse and was well entrenched in the medical community. She didn't believe it. She breastfed all of her children. She had 10 kids, and they were all very healthy. They all did just fine. But yeah, that was. What would we think about that now? Yeah, I think most people would say that's terrible advice. But nevertheless, I was pretty generally understood back in the 50s and 60s. How about the ice pick lobotomies? You guys remember these? You can see videos of this online. That was traumatic. We watched one of these videos when I was in medical school. They just take it wasn't technically an ice pick, but that's what it looked like. They would take a long spike and just hit it up into right up above the eyeball with a wooden mallet, and then they'd kind of jerk it back and forth and shred your frontal lobe. Does anybody know what happened to the guy who invented these? He got a Nobel Prize for it. Yeah, I don't remember. I meant to look this up. I don't know how many ice pick lobotomies were done. It was in the tens of thousands probably. They were so fast. It takes 5 minutes to do these. You had all these, hundreds of thousands of vets from World War I, World War II, the Korean War, who had severe PTSD and shell shock, and they were in sanatoriums, and you'd give them these lobotomies, and all of a sudden they'd be totally docile and peaceful people. Anyway, we don't do these anymore, thank heavens. But that's a good example of another big mistake. The whole medical community as a whole thought of this as a revolutionary treatment. Hey, this is phenomenal. Look what we did. Okay, look what we've been able to accomplish. How about the food pyramid? There have been several variations of this. Does anybody remember that, where you have all the bread and carbohydrates on the bottom, and then, I don't even remember, I think vegetables, and then meat, and then fats, and sugar up at the top, something like that. What do we think about the food pyramid now? Any ideas? Yeah, the food pyramid is terrible advice. No dietitian in their right mind would tell you to look at the food pyramid. What's that?
It was great marketing.
It was good marketing, yeah. Yes, they were both good marketing, weren't they? And I will say, this was not developed, the food pyramid did not come from the American Medical Association. This came from the USDA, I think. The United States Dairy, is that right? Anyway, it didn't technically come from the medical community, but it was adopted. I remember when I was a kid, I saw this up in my doctor's office. And of course, in the school lunch, cafeterias, they had this everywhere. Anyway, big mistake. That's a lot of people are blaming at least some of the obesity epidemic in the United States on the food pyramid. I don't know how much blame that can really get, but probably part of it at least. Before I go on, any other big catastrophic mistakes the medical community's made, Dr. Edwards? What's that?
Narcotics.
Oh my gosh, narcotics. You guys remember that? What went along with narcotics? The pain is the fifth, what was it called? The fifth vital sign. What do we think about that now? Yeah, we don't really think that way anymore. But I was in medical school when that was, I would say I was kind of on the tail end of that, but I was still taught that it was the fifth vital sign, and if somebody is in pain, it means they are not on enough narcotics. Yeah, that was terrible. What a disaster that was. Any other big ones? Yes.
I think in our profession, the term arrest, dice, compression, elevation, the
Okay.
doc that coined that term came back out and said completely wrong. It's not how we should handle injuries. We shouldn't be resting them to that capacity, right? We need to be moving them. We need to gently progress them. There's just completely new terms that are bigger and better than the rice term.
Absolutely. That's a great one. I remember, I remember my son sprained his ankle once, and his anyway, we got in an argument between my kid's doctor and my son. Anyway, so any other big ones? Yes, I was a doctor at the time. My son and my wife don't trust my medical judgment, so they do not ask me. My wife asks me for medical advice all the time. She never takes it. She always, anyway. So,
You won the argument, right?
What's that? Yeah. I ended up winning the argument, yes, because it turns out that you can walk on a sprained ankle. Yes, that's the point here. Okay. So these are some recent ones, and these are actually kind of ongoing controversies I wanted to cover with you, because I wanted to talk about the way we get some of these guidelines. How about, oh my gosh, this is a hot topic right here, masks to prevent the spread of COVID. What is the consensus right now about how effective masks are? Does anybody know? When was the last time somebody looked this up?
They're completely ineffective.
No, they are not completely ineffective. Or I should say, it depends on which one of 10,000 studies you want to look at. Okay, that's the answer here. Okay, in 2021, a friend of mine sent me a link to an article saying, he said, the whole COVID mask thing has been completely debunked. There is absolutely no benefit to COVID masks. And he sent me a link, or masks to prevent COVID spread. He sent me a link, and I looked it up, and sure enough, there was some study from the Netherlands where they gave some people masks, some people didn't, and they tracked spread and stuff. Anyway, so I was like, well, that's interesting. I wonder if there are any big meta-analyses about this. And I went on PubMed and I went on Google Scholar. There were 5,000 studies. That was in mid-2021. 5,000 studies about oh my gosh, masks and COVID spread. 5,000 studies. And what did they all say? Completely, they were all over the place, okay? To this day, I cannot find a good definitive study. I looked it up again. I was curious if there had been any updates. Part of the problem is that these are big population studies, and populations vary from, like, even here in Utah is not the same as New York City. This is not the same as, like, Goshen. You know, this group in Utah Valley is not the same as Goshen. So different studies are going to show vastly different things. I don't know how effective masks are. After reading this for years and being in the middle of it myself, I honestly don't know. Nevertheless, going back to the overall theme of this, remember I started this with the question, or the phrase, "Trust me, I'm a doctor." So if I am saying I have a definitive answer about COVID and the spread of COVID with masks, I am probably incorrect. If I have ever said I have a definitive answer, you must believe what I am saying, I am incorrect about that, okay? So how about this one? Finish your antibiotics. If I give you a 7-day course of antibiotics, you absolutely must finish that 7-day course of antibiotics. Does anybody know what the current studies about this show? Anybody? How many people have said that to patients? Yes?
I'm currently reading a book about the over-prescribing of antibiotics.
Yeah. There are 1,000 studies about overprescribing of antibiotics, and the IDSA, the Infectious Disease Society of America, is pushing hard to have us use shorter and shorter and shorter courses of antibiotics. I read one study that showed with cellulitis. When I was in residency, if somebody got cellulitis, you would have them on an antibiotic until the redness was completely gone. Okay. Which might be 1, 2, sometimes 3 weeks. The redness, when it was completely gone, then you would stop the antibiotics. So they were on long course of antibiotics. There have been a couple of studies now showing that as soon as there is any improvement at all in the redness associated with, in the redness, pain, heat, any improvement, you stop the antibiotic, and there is no difference in outcome, okay? That is not a generalized recommendation yet, but there are studies showing that. How about for sinus infections, which I deal with day in and day out? The current guideline, or the current from the Sanford Guide for Antimicrobial Therapy, says it's supposed to be a 10-day course of Augmentin for a sinus infection, or at least a 7-day course. Is that, so if I am telling all of my patients to stay on a 10-day course of Augmentin, is that in keeping with current studies about the effectiveness and how long you need to be? The answer is no, it's not. Okay. How about finish your antibiotics to prevent increased antibiotic resistance? What do current studies and current wisdom say about that? Does anybody know? I'll just, spoiler alert, no, there's no evidence that stopping antibiotics early contributes to antibiotic resistance. Okay, we've actually known that for at least 25 years. But doctors still say it. Prescribers still say it. If you don't finish your antibiotic, your 5, 7, 10-day course of antibiotic, it's going to increase antibiotic resistance. There's never been any evidence for that. And when I was in undergrad, actually, we got, in microbiology, one of my professors got in an argument with a student about this. Anyway, the student was saying that you do need to finish your antibiotics or it increases antibiotic resistance. The teacher said, absolutely not. That is not correct. Anyway, so at least 25 years we've known that that is not the case. How about stretch before exercising? Does anybody know about this? What do you guys think about that?
Yeah, like long form stretching before exercising is highly not recommended. Some kind of dynamic warm-up is probably the way to go.
What do you mean dynamic warm-up?
Some kind of movement involved versus like a static hamstring stretch where you reach and touch the floor. Maybe some Frankenstein kicks or something like that where you kick the leg up as you're walking.
Cool.
And static stretching has actually been shown to increase risk for injury. So all professional sports, high school sports are moving towards these dynamic warm-ups rather than static. So static would be just holding a stretch for a long period of time.
Okay.
Now, if you're trying to create a sport where you're doing the splits, like static stretching is going to be your best bang for your buck. But if you're doing it before the activity, it's more likely to increase your injury.
Okay. So let me ask you, I'm not picking on you guys specifically, but have you been taught the opposite of that earlier in your careers or training?
Yeah, we did I'm not sure if you did the same lecture in Ed's class. Were you in that?
Yeah.
So in Ed's class, well, this class that we had to do, we had to take like 5,000 articles in stretching. And we literally looked at all these different aspects of stretching. And this was only 5 years ago. Mm-hmm. And the majority of the articles said that stretching was great. You should be doing it 3 times a week. You know, and then the newer research just 2 or 3 years ago says absolutely not static stretching, that it increases risk for injury. So, you know, stretching has a long history of research, but the most accurate, the most up-to-date research says static stretching is ineffective unless you're trying to elongate or increase the lactic, or what's the word? Elasticity, yes, thank you, of the tissue. Say you're a dancer and trying to do splits.
Mm. Okay, excellent. How about this one? Don't eat much saturated fat. There was a big article in the British Medical Journal a few years ago. Said we cannot find any evidence that saturated fat's bad. Yes. Oh, you raised your hand. Yes.
I'm sorry, I was giving you a 5-minute warning, Dr. Hardman.
Okay.
I have nothing to say.
Okay. Anyway. Does anybody remember this recommendation? Hopefully everybody here should recommend that because a lot of people are still saying it. There's no evidence that saturated fat's bad for people, or at least it does not directly contribute to heart disease, okay? How about this one? Don't eat much cholesterol. Same thing, right? It's questionable how much negative impact cholesterol has, at least on heart disease. How about this one? Yearly PSA testing. Older doctors remember this, that you get PSA, for those of you who are not in family medicine, is prostate-specific antigen. It's a way to test for prostate cancer, okay? And when I was going through medical school, they told us this is part of your yearly screening, and when a guy comes in, every guy after the age of 50 needs to get a yearly prostate exam and a yearly PSA. So what do the current guidelines say about that now? Anybody know? You shook your head no.
I think PSA, the Institute of Medicine decided that PSA testing was useless. I believe over patients over 70.
Yeah, what does the American Urological Association say?
Well, they contest it.
That's right. Yeah, there's actually not that much consensus about this. The American Academy of Family Medicine and the U.S. Preventive Service Task Force, they said, we looked at all the data. We can't see that there's much benefit to checking PSA every year.
There was actually harm to it because patients had
That's right.
biopsies, they had a surgery done for for comparatively low-grade lesions.
That's exactly right, yeah. The American Urological Association looked at all the same data and said, oh yeah, we definitely want you guys getting your PSA checked every year and get a digital rectal exam every single year. So if you believe in conspiracy theories, the American Urological Association obviously has gets a lot of benefit from us doing PSA testing because we refer so many people. If I am doing yearly PSA testing, it means I have to, everybody who has an elevated PSA has to go see a urologist and get a biopsy. And so I don't know if I believe that's what's that? Yes.
You were mentioning that like blind biopsies, that at least here in Utah, I know for a long time that's kind of been the norm for testing prostate cancer and different things. I work for Envision Imaging, so in our other markets, such as Colorado and Texas, they were coming in here and they're like, what in the world, we're still doing blind biopsies like here in Utah, like in Texas, Colorado, other places. Prostate like MRIs are now becoming the norm for checking that, where again the risk is not nearly as high. So
Yeah.
it's kind of an interesting thing.
It is, and as technology changes, it's going to change. How about this one?
The
This,
point they made, though, was that
Yeah.
prostate cancer was so prevalent in people my age.
yeah,
It's almost universal when you're 80 to have some degree of prostate cancer.
that's right. Yeah, in fact, there are studies about where they've done biopsies on, they've done cadaveral biopsies in guys in their 20s and 30s, and most of them have traces. You can find evidence of prostate cancer. How about, oops. What did I do? Oh. How about yearly versus every other year mammograms? Anybody know the consensus here?
Every year?
What's that?
Every other year?
Depends on who you ask. Yeah.
Okay.
Yeah, when you look up breast cancer screening guidelines, there's a big chart will come up saying the ACOG recommends this, USPSTF recommends this, the radiology people recommend this. They're all different. Everybody has different recommendations about that. In a lot of European countries, they don't even do mammograms. They use ultrasounds for a variety of reasons. Anyway, my point here is not necessarily that these are all incorrect. My point here is that there's a lot of unknowns, and we change our minds about stuff like this all the time. We are always changing our minds about stuff like this. And we are almost out of time. That's ridiculous. My point here is we change our mind all the time, okay? So, when we say or think or feel, when somebody comes to us and we say, you need to do this because I'm a doctor, what does that mean? We have just established the whole medical community has been wrong 100 times, okay? Catastrophically wrong sometimes. We are still uncertain about a whole bunch of things that we tell people. So what does it mean? Should patients, that's the question I want to ask you guys today. Should patients trust us as medical providers? What do you guys think? Yes, Dr. Edwards.
I think we really have to earn it, right? And we haven't had, as a profession, a lot of reasons for patients to trust, or a lot of reasons patients would not trust us.
Mm-hmm.
So one of the things I was thinking when you listed all these out is, why is so much of this controversial? Today's an election day, obviously, and why do we have people so polarized on how to do everything? And I think some of those things with human nature and the way and self-interest and things come into play in our medical decision-making and policies, and there's money to be made by certain entities, and there can be a lot of bias as a result of a variety of these things. And so I think we can earn the trust by always putting the patient's care and their outcome as our top priority. And I love the venue here because that is our priority, right? And we're not closed-minded in these conversations as to what could be a better way or what insight does somebody else have. You don't want to be that way because we could be wrong. And so being open to that, and then just keep putting that patient outcome as the priority, and constant vigilantly looking for ways to improve it, not in the short term only, but in the long term, I think is how we gain the trust that patients can and should have in their medical providers. And then that relationship with trust enables us to help them with a greater capacity. So it's really a good conversation around how we can maybe better maintain that trust.
Yeah. Yeah, and I have to apologize. I did not realize the time was moving so fast. This is the whole conversation I wanted to have here. Dr. Bowden told me I had 10 minutes for slides and then I was supposed to have 20 minutes for discussion, and I messed that up and I apologize. The whole idea here, and unfortunately we're out of time, the whole idea is why should they, like Dr. Edwards was saying, we really have to be aware of our own we really have to be most interested in patient outcome, and as clinicians, we really have to understand our own limitations. Okay, there's a lot that we don't know. It changes all the time, and if patients come to us and we say, you have to do it this way, and they have concerns, I don't know if I want to do this. I don't know if I want to be on a statin. I don't know if I want to be on a blood pressure medication. I don't know if I want to start on this medication or do this regimen or have this surgery. There has to be space, there has to be a place in our minds when we think about this conversation to think, you know what, my patient might be right. Or I might not actually know what the best thing is for my patient. And conversations like that are much more mutually beneficial. I learn a lot from my patients when they bring stuff to me and say, hey, I have these concerns about these medications or this plan of action. I learn a lot from that. And we could go on, and we're just out of time. I will tell you that as an individual doctor, I am not up to date on all the guidelines. I just am not. There is no possible way I can stay up to date on this. I have a nurse practitioner I'm working with yesterday who corrected me on something I've been doing for 20 years. And she said, that is not how you're supposed to be treating this condition. And I did not know that, and I felt foolish. And so we're done. I wanted to show you guys one thing. That question where it said 7,000 people a year die from medical mistakes, that was just Google AI gave me that, and it could not give me the reference to it. I want to emphasize to you how often things get into the medical community that we don't know what the source was, and we just do it that way. Anyway, I'm sorry that I used all the time on those slides. I wanted to have more of a discussion. I apologize. Any other questions or comments real quick? Okay, I guess we are all done.